presentation. If you have questions, you can post it in the chat, and the moderators, Dr. Kirsten Tracy and myself, will monitor the chat and help navigate the Q&A. So today we have with us Dr. Mark Levine. He has been the Vermont Commissioner of Health since 2017. He is also a professor of medicine at the University of Vermont, and most recently has been the Associate Dean for Graduate Medical Education and the designated institutional official at the College of Medicine and the UVM Medical Center. He also served as the Vice Chair for Education in the Department of Medicine here at UVM. Dr. Levine has gained a reputation as an outstanding teacher and educational program innovator, receiving teaching awards from the medical school and the Department of Medicine here at the University of Vermont. He maintains his faculty appointment here and continues to actively teach. At the nexus of Dr. Levine's clinical education, public health, and advocacy efforts is his heightened interest in improving health at the population level through health policy directed at fostering a culture of health. As Health Commissioner, Dr. Levine takes great pride in leading the Department of Health's efforts to fulfill its mission, which is to protect and promote the best health for all Vermonters, and is honored to represent its vision of healthy Vermonters living in healthy communities. Today, Dr. Levine joins us to give us an update on the COVID-19 pandemic, current status, and future projections. Thank you, Dr. Levine. Take it away.
Thank you for that nice introduction. It would be nice to go back to that culture of health and all the problems that I thought I would be addressing in the last year or two. But here we are again with a COVID presentation. Let me get the share screen thing going here, which I think should work pretty easily. Is everybody seeing one slide and not my whole screen?
Yes, but we are seeing your presenter view. You might want to switch that.
How's that?
Perfect.
Okay. So I've never talked on a topic that changes almost every day. And every time you talk about it, it's already outdated. But I've got some pretty up-to-date things in here. And some things don't change in terms of our ability to pontificate about the future. So let's see how this goes. And there should be plenty of time for questions. It's always good to talk with this group. I feel like even before the pandemic, a few times a year, we would always commiserate on lots of interesting things. So my objectives today are, as Bill, to give an update and a little bit about how we got here, and talk about challenges because they continue and will always continue. Variant strains are sort of the hot issue, and what are the implications? So we'll talk about that. And the futuristic part as well. So, you know, we've been through a number of variant strain surges, and you may remember at the beginning of this year, the UK B117, and now, of course, we're in the thralls of Delta, which hit a lot of our country in the summertime in terms of really peak activity, and has only more lately come in full force to the Northeast. And now, of course, spreading across other northern states across the country as well. But if there's anything true about a variant strain, it is, number one, a pandemic. So it is a worldwide impact that it has. And it becomes successful and outcompetes other strains and becomes dominant. And that's exactly what we've been seeing all along and what we'll continue to see in the very near future. We certainly know that the fundamental basis for these variant strains has to do with mutations in spike proteins, which of course impact our ability to bind, the virus's ability to bind to the receptors in our nasal cavity. And the most curious thing about the newest Omicron strain is just the sheer number of mutations in these spike proteins. That doesn't mean that mutations in other parts of the viral genome are not important. And I wish I could give you more definitive word, but we're actually still in the process of learning about how not only the vaccines, but other viral therapeutics may work based on the newer mutations in the non-spike protein part of the virus. Clearly, there isn't even a consensus yet about some of the past variant strains with regard to ability to cause more severe illness or greater risk of death. But even when they're billed as less likely to cause death or hospitalization, because they are so adept at finding more and more susceptible individuals, the sheer numbers of people that are impacted lead to higher numbers of people getting hospitalized or dying, even when the rate does not get impacted. And that's an important concept. To date, we've not been able to find that the usual mitigation measures don't work for one variant versus another. They are capable of working for all of them. We're also learning a bit about fear factors, and there have been several times when fear of Delta, mainly because of people seeing what it did to their family members and friends, caused people who were previously more resistant or skeptical for vaccine uptake to actually get vaccinated. So, from my standpoint, whatever it takes to get somebody vaccinated, it's never too late. So if there's a pre-Omicron surge of vaccine uptake because of fear, so be it. We'll take it. Absolutely. And that's why it's very important for us as we go along to message that even if the ability to get infected isn't altered as dramatically as we'd like by a vaccine, the ability to not have a serious outcome is, and that is indeed why we vaccinate in the first place. So I think that's really, really critical. Let me move to the next slide. Just a capsule, why we were successful through much of 2021 with the UK strain, all had to do with the fact that we became more sophisticated. We knew that we didn't need to we could surgically address the virus and strategically address it, as opposed to let's just do a lockdown and have that blanket response. And we knew that there were two things we had learned from the year 2020, and as we were approaching that B117, first was travel played a big role. And at that time, the travel map was heterogeneous. It wasn't all red everywhere in the US. So we could actually be very specific about requirements for quarantine and travel maps. And then we knew household gatherings were playing a big role. So we could be very specific about that because the state of emergency was still in effect at the beginning of this calendar year. But we found that we didn't have to do much about retail business, about one-on-one contact, like with healthcare, dentists, hairdressers, etc. Telework still was good advice, but it wasn't absolutely essential. Anything outdoors was safe. Gyms could actually be run in a very responsible way and stay open. Restaurants and bars, not so much still, because people were still gathering together, often unmasked, and often with disinhibition, especially in the bars, so that we still needed to be active about those. Then, as you recall, we had a great summer in June and beginning of July were great, and then Delta came. And though people object to calling it the pandemic of the unvaccinated, it clearly has proven to be so. It's been fascinating to watch evolution occur in real time. We're not dealing with primates taking God knows how many eons to evolve to human beings, but we're talking about viruses that are doing it right in front of us and showing us the fact that a large unvaccinated pool is actually great substrate for more transmissible strains to develop and mutations. Not to be perceived as less than scientific, though, I also subscribe to the issue of more immunocompromised pools serving as a substrate for more mutations as well. And there's a lot of data coming in regarding the length of time the virus survives and can still do a lot of damage in a host whose immune system, whether vaccinated or not, is not up to par, and how that allows it to go through more iterations of mutation-producing processes, if I could call it that. And now with the recent Omicron coming perhaps from the southern part of Africa, and that being a hotbed of HIV in the world, that theory is gaining even more and more traction because of the immunocompromised state of an untreated HIV individual. So I just put that on the table because I'm sure this audience has been thinking about things of that sort. Delta, of course, has a different transmissibility than the previous variants. Generally, the United States has the good fortune of having other places in the world to look at, and Vermont has the good fortune of having other states to look at before we have to actually contend with this. Very early in Delta, I was very proud to say that having the highest fully vaccinated rate in probably the world, never mind the country, was going to help protect us to some degree. But you've seen how that's played out more recently, because the reality is even a significant unvaccinated state of 40 or 50,000 people allows plenty of virus transmission to keep occurring and more cases to develop. But it did protect us and has altered the curve in Vermont. So if you think about some of the southern states that had literally a 50% or less vaccination rate, the curve in those states was straight up and straight down. Just a huge wave of infection, overtaxing the healthcare system, not flattening the curve. If you look at the experience in the Northeast and Vermont particularly, it's a much more less highly inclined curve and more suppressed curve, which has really protected our healthcare system to a large degree. The importance of 2 doses of an mRNA vaccine has come to light, and that continues to be true. And I'll show some information about that, and the importance of boosters. So everybody asked today, why we having so many cases if we still lead everybody in vaccine? So clearly the variant matters, and the variant's transmissibility pattern is a factor, no question about it. The population matters as well. And in spite of being highly vaccinated, we were so successful in vaccinating people early on, especially the most susceptible, that their vaccine-mediated immunity waned very early. And until we learned more about that and the power of a booster dose, or if you prefer to call it a 3rd dose, since we actually now call it a 3-dose series, that played a big role in why Delta could really do its damage. I still am a little amazed that our rate of boosting is only about 50% for age 35 and older, even though that leads the country. That is far from good enough with a virus that capitalizes on waning immunity. The other thing about our population being susceptible is that perhaps, and I get this from seroprevalence data provided by CDC random sampling of our population and the Red Cross, only a 3% or so rate of infection prior to Delta. We had done a phenomenal job of protecting Vermonters from this virus But when Delta came along, there was little infection-mediated immunity in the population. And then we have the population factors. So the pandemic of the unvaccinated really applies to this because people's social networks, the way they cluster in social clusters, especially rural pockets, become a place where the virus just takes off. And it's so adept at finding this part of the population that it can keep cases going quite a long time. There's also a huge change in our mobility because in earlier days, people were not mobile. And of course, if you are, you shouldn't be surprised by the fact that people have had pandemic fatigue. People who are vaccinated feel like they can make appropriate decisions about their life and do the kinds of activities with others they want to do. And they have little appetite for a restrictive state. And they're paying attention, unfortunately, a little less to the traditional mitigation strategies, which is problematic, but understandable. As we approach Omicron, and I'll come back to Omicron later in the presentation, but for every variant, whether it's Omicron or the next one, how much more transmissible? Does it cause more severity of illness? Can it evade vaccine-induced or infection-induced immunity? And then the usual Darwinian natural selection factors in respiratory viruses. So we'll come back to that. Here's where we are now. I'm showing you the epi curve on the left, which, believe me, that is a gentle slope compared to a state like Louisiana or Mississippi, where it literally was straight vertical, peaked and then came straight down. So the surge in the Northeast, unfortunately, is a prolonged surge because we have had such a highly vaccinated population that it's taking more time for the virus to sort of pass through, if you will. Most recently, though our numbers are not anything to be super excited and proud about, we are actually having a decrease in the last 10 days or so of our case growth. Same is true for hospitalizations. They've actually, they got up into the 80s per day. Now they're 60. The ICU is still in the mid to high teens, but there's a lot of access to hospital beds and to ICU beds right now. And then, of course, the positivity rate, which really spins off of how well are you testing. Well, we continue to test tens of thousands of people every day, anywhere from 8,000 to 20,000, I would say. And though some people are accessing antigen tests and we may not know their results, we feel we have a pretty good handle on Delta still at this phase of the pandemic. And our positivity rate is now 4.5% on the way down. We'll see how long that can continue. Still a very huge difference in the impact of being vaccinated and not. And even though those numbers are changing, it's still a 5-fold difference in your risk of becoming a case based on your vaccine status. And of course, when we look at ages, this is what we tried to show the population in the beginning of vaccination, just to prove that we were right in a sense that if you get vaccinated, your case rate's going to go down. And of course, we used an age banding strategy. So as you look at the older ages on this slide, you'll see how the cases came down very nicely in the beginning of the vaccination campaign, and now more recently in the boosting part of the vaccine part of things, which is nice to see. But you'll also see that if you're in the ages from 20s to 50, that's where we're seeing most of our cases these days. And I suspect it's in the unvaccinated portion of the 20s to 50s. And you can see that vaccine uptake leveled off in some of those age bands at a lower level than in the older age bands. Our youth under 20 still account for about 20%, sometimes 20 to 30% of our cases each day. And that's, of course, evolving as we get more and more vaccine into the 5 to 11 age group, which has really led that part of the population. And here is the pediatric glimpse of how things are going. You see a slight downtick in the infections, but obviously we're still on the uptick part of vaccination. The 5 to 11, we are now at 50% having gotten at least one dose, and almost 30% having received a full vaccine schedule. That's leading the nation. Clearly not good enough yet either, but real tribute to the parents of Vermont, because most of the country, you're lucky if you got a third in the early adopter group, and then you can work on the third that are sitting on the fence. And we've already eaten into that second third pretty nicely. Whether we get to the final third, which is the more resistant part of the population, remains to be seen. Good progress, though. I mentioned on an earlier slide the impact of being fully vaccinated. This is in an earlier part of the pandemic when states like Hawaii were actually going vertically up, as you can see. And I just show you where Vermont was at that time. And we had 11% more people fully vaccinated than Hawaii did at that time. Little did we know that even then, immunity is waning. And we've learned much more about that since. It would be nice to see if boosters had been administered sometime then, how the different curves would look. Here's where our age-based cases are going nowadays. They're all coming down, but clearly you can see that the 0 to 24-year red band there has been leading the charge in going up, and now it's coming down. And then the 25 to 49, as I pointed out, pretty much equaling that more currently, but also coming down a bit. And then the older, which tends to be the more heavily boosted population, coming down, but having never been as high as these other age ranges. It's very instructive. Also instructive is this data that we showed at the press conference this week that basically shows your risk of being hospitalized if you're fully vaccinated, meaning 2 doses, fully vaccinated and boosted, meaning the 3 doses, or not vaccinated. This number is really alarming. Now it's focused only on a 6-week period most recently, but that's when we've had our Delta surge. Overall in the nation, it's more like a 10 or 15-fold change there. And then deaths, also significant impact of vaccine, obviously. When we look at our booster success rate, we're right up there at the top of the country, which again is still not good enough. This is over age 65, where we should have our highest rate, but we don't yet. Anything else like age 35 to whenever, we are number 1, as opposed to, I guess, on this slide, number 2. And here's the illustration of that delicate age time between 20 and 40 or 18 and 40, where we have our lowest uptake of vaccine over the entire course of the vaccine strategy here. You can see that our adolescents have really rallied to the cause and are in the 80% range now. And where we are, of course, with our older populations, where we're doing great. But every time you see something under 100%, you know that the virus is adept at finding those people. Let's move into a little discussion of the challenges that we've seen in public health. Certainly, for decades, which means not just one infamous president that's no longer in office, but for many administrations of both parties, public health has taken a hit. It's been chronically underfunded because the CDC has been chronically underfunded. Emergency preparedness funding has been reduced, not increased over the years. in spite of calls to alarm. The public health workforce, which is, as stressed as any workforce is right now, was decreased by 10 to 16% over preceding years. And there is complete lack of modernization in data systems. So we've had a huge infrastructure bill just passed by the president. Data systems are really another piece of infrastructure that has been underinvested in. The head of the American Public Health Association basically said that the public health budget needs to grow by $7 billion to address new and chronic diseases, and put that in comparison to what's a pandemic cost without control, trillions of dollars. So a good investment. There's been an incredible impact on all of us, on all of those in healthcare, and on all of those in public health in terms of mental health. And the CDC came out with an entire MMWR, which basically showed 53% of the public health workforce talked about the adverse impact on their mental health, whether it be anxiety, depression, PTSD, or suicidal ideation. All of those were key players, as you can imagine. And then misinformation, the Surgeon General has labeled that as a public health crisis and drawn a lot of attention to that. Some of that has to do with public trust in science, unfortunately. But we all know about the impact of the dark web and things on the internet that people buy into and can't separate themselves from, and can't even be compelled to look at other data once they're hooked. Don't have to tell you, a 50-state strategy proved to be a flawed strategy in this country. I do want to call attention to implementation science, because it is an equally valid and important part of science as bench research is. We have wonderful discovery process of getting great vaccines. And then what happened in this country? It was a totally flawed process of getting those vaccines into people. And it took a lot longer than it should have. You should be proud of Vermont, because we kind of solved that problem on a smaller scale within our state, even though we got criticized a lot about our allocation strategies and our age banding strategies, et cetera. Our goal was keep more people alive, and we did that. But implementation science has been so critical throughout the entire pandemic, whether it's using good science about the value of PPE, whether it's the importance of testing and testing platforms and how to carry that process out, or whether it's vaccine. I won't spend time on racial equity today, but it's been a core problem exposed by the pandemic in a very dramatic way. And then on the mental health theme again, we've always known social isolation is a really prevalent and really core public health problem that leads to all other problems, whether they be substance misuse, eating disorders, or psychiatric disease. But what better setting than a pandemic, when we tell everybody to lock down, stay home, stay safe, to see all of these adverse outcomes flourish. And just to show you one of them, since it's been in the news, nationwide, the opioid unintentional overdose death rate has just skyrocketed. Vermont was called out because we had, depending on the date of the year you started, some of the highest percentage increases in our overdose deaths. And here's the data that supports that. Real tragic aspect. But there are plenty more tragic aspects, as I'll get into. So a little bit about the future, and we'll segue into Omicron and then questions and answers. Clearly, you can't get through a Delta surge without having a lot more people have what's called natural immunity. I just got some recent data from the CDC, who continue to do their seroprevalence studies, and the Red Cross, through their blood donations, also do the same. We are now up to, I think, 7.6%. Still not super high, but higher. But that data is pre-October, because that's how there's a lag time in there getting the data to us. So I suspect once we know October, November, December, it will definitely be in the teens %, which will still probably be the lowest in the nation because we are currently at 7.6%, the lowest in the nation. And the nation goes up to numbers in the 40% range. But clearly, we're going to have a lot more people with natural immunity and, of course, our good starting point of people with vaccine-mediated immunity, which always raises the question, when is it going to be endemic? People were hoping like tomorrow, and much of our population in Vermont, if you look at what's going on with gatherings, with people going to bars and restaurants, with people going to events, for them, it is endemic now. I've tried to slow that down. I've started press conferences by saying the pandemic is not over, but people have kind of had it, and their fatigue has shown. This will become endemic probably as a result of Omicron, because if Omicron does what it's promised to do, which is infect way more people than any variant before, it will pass through pretty quickly, have a big impact, and then hopefully we'll be able to sort of regard the next phase as we have another annoying respiratory virus around that we just have to live with and deal with, like we do with the flu and other common cold viruses as well. That's sort of the way things are projected. I had always thought March would happen. With Omicron, I don't know how many months to give or take in that process. But it is fascinating, and I'm sure not lost on much of this audience, that the most successful variants not only are more transmissible, so they can infect more people and keep themselves going more, but they clearly don't kill as many people and cause as many severe outcomes. So if we're on the way to a SARS-CoV-2 virus that looks more transmissible but doesn't really have the big impact anymore, it will dramatically change our approach, both individually and population and public health-wise, in the way we address this virus and how we respond to cases in the future. And that's what you'll see. And there's going to be a complete transition from case-based data, which everyone loves to focus on now, but is less meaningful, to hospital and death and other serious outcome-based data, which is really what we need to always have our eye on the ball with. And that's really how things are going to travel. It's also going to be because of what pivots are made in the testing system. Testing is going to become a far less state-run, go to a place, get a PCR test philosophy, to get your own antigen test, hopefully for free and through the government, have them at home, use them wisely when you're going out and doing things or when you become ill. And how are we going to keep tabs on case numbers at that time? We know from previous experience that if we're lucky, 5% of people will report a positive antigen test to the health department. So no matter how user-friendly you try to make that, you're just not going to get all the reports. So that's why you're going to see changes in that as well. Once we get through Omicron, I think we will see less volatility and less surge activity, but we get this one more surge to go, unfortunately. And that's what the winter has in store. I've taken away the word booster from this conversation today and said it's really a 3-dose series, but the reality is, I don't see any way that there won't be further shots in our lives in the future. Maybe there'll be the same exact vaccine we're getting now. Maybe they'll be like flu vaccines where they actually do get altered because of things like Omicron and other variants coming into play. But either way, it'll probably be an annual event unless things dramatically change in another way. The biggest fear, which I've expressed before and which is playing out on the world stage right now, is that not only as the United States of America, which has vastly discordant vaccination uptake rates throughout the country, but the world having vastly discordant rates. So in the US, we still have southern states that 50% fully vaccinated looks good to them, but it's far, far from adequate. And then in the world, we have African nations that have 2% fully vaccinated. So clearly, we need to change that if we're going to stop living in a pandemic society, for sure. And so it's very heartening to hear how many millions of doses, actually hundreds of millions of doses, the US is now sending elsewhere. But keep in mind, they got a long way to go. There's billions of people in the world. There are many countries that have their own problems with vaccine hesitancy and skepticism. And the implementation science part is a lot to surmount for many of these nations. So we're not there yet. I mentioned climate change because every crisis leads to opportunities, and you need to seize those when the moment is there. And there's a lot about climate change that has to do with respiratory medicine and lung health, and the pandemic only helps us advertise that. There's also a lot that has to do with health in general when it comes to vectors like mosquitoes and ticks. We all know what's happened here in Vermont, and there's only more of that in our future. So that's very important as well. And then we also know about just what's happened to the environment with regard to breathable or edible or some other form of toxin that drinkable in our drinking water, et cetera. We're constantly finding how we've trashed the environment, but we're also finding how climate change impacts that environment. And it's a wake-up call for all of us. The last bullet on this is testing strategies, which I think I said enough of at this point, but just keep in mind that probably not before New Year's, but sometime in January, everything will be straightened out, we hope, with regard to supply chains for antigen tests, with regard to insurance coverage of them for the insured, so you don't have to buy them yourself and then get reimbursed, but it just, you get them. Distribution process for those who are less insured or not insured at all and more vulnerable. But antigen testing will be what we do, except where PCRs are mandatory, such as for international travel still, for people who are symptomatic but highly suspect for COVID and have a negative antigen test, et cetera. So the do-it-yourself approach will become the approach. And that has implications, as I pointed out, but it could lead to a much safer society to exist in if people are responsible about their use of those tests. But again, PCR won't go away. The apparatus we've set up won't go away. But this is the way you get more nimble, because you'll have a result in 15 minutes as opposed to 48 hours. Surveillance testing will continue, but the question is what populations will it continue in, so we have a good handle on things. Wastewater sampling will continue, and whole genome sequencing will also be something that we finally achieved success in as a nation, and that will continue so that we know about variants much quicker. Will we become like Asia and actually embrace masking? We're certainly not seeing that in this country now, so I guess the answer is no. Will we shake hands? A lot of people are still doing that. A lot of people are using the elbow bump or what have you. It's a little unclear how that will evolve. How will we contend with all the people who've gotten COVID over this last 2 years, many of whom do have long COVID, perhaps 20 or 30%? It's a syndrome we don't understand well. We don't have good diagnostic criteria for. We have very little in the way of therapeutics because we don't have specific things that we can throw a medicine at. So it's more things like rehabilitation medicine, physical and occupational therapy, behavioral counseling and therapy, which are the things that are hardest for our society to deliver on and put together. We're also seeing very much in our hospital crisis now, the impact of delayed healthcare and missed screenings. So we have people who purposely avoided the healthcare system because they thought it was a dangerous place to be, even though it turned out to be the safest place to be, and have still not gotten back in the system. They've missed a lot of preventive screenings, and a lot of chronic diseases have either not been uncovered until they've gotten significantly bad, or have just progressed and are now at a crisis level. Those indeed are the patients that are filling the hospital beds these days. The COVID patients are well under 10% of patients in any hospital. It's these patients. So we have a lot going on there. Seasonal flu, we have found some cases this year, but it's by no means widespread. People are fearful it will have a bigger season. I can't really say either way right now. For us, it usually is earlier in the next year that we'll learn that more. Suffice it to say, there are many respiratory viruses that have had their field days recently. RSV at a time of year in the fall when we don't see it as much. So I suspect the flu will also thrive to some degree. I have another slide on antiviral therapeutics, so I'll talk about that in a second. I've talked about the mental health and PTSD and all of that, and chronic disease. So let me move on to the treatments. Monoclonal antibodies have had a checkered history. They began as not embraced by the clinical community as much. In fact, the NIH and the Infectious Disease Society of America didn't actually buy into the evidence. So they perpetuated that lack of faith in these modalities. But a lot has changed since the beginning of the pandemic, and now there's a wonderful evidence base. Everybody embraces them, and they actually do have a big role, especially in the unvaccinated or in the compromised people whose vaccine isn't working up to speed, to protect them from hospitalization and death. And we've got a great implementation science project working here in Vermont now, making sure that we assist every hospital in their ability to infuse these in their infusion centers. We assist every long-term care in getting them delivered to them, and if they need help with infusion, getting them help. And we have EMS resources really augmenting the hospital healthcare systems all over the state. It's been a really good project. Just authorized was Evusheld, which is a long-acting antibody combination for pre-exposure prophylaxis. That means those people that we know ahead of time are going to have a harder time if they get the virus because they are immunocompromised, because they may be allergic and couldn't get the second dose of vaccine or what have you. This has been shown to be very helpful in reducing the risk of symptomatic COVID. It's feared that this may not actually work with Omicron, but we don't have definitive answer to that question just yet. But this obviously is a great intravenous preparation that has a very limited audience. For a larger audience, we have molnupiravir, which any day I think will become authorized for use. The unfortunate thing about it is the statistics have gotten worse. It started out billed as maybe 50% protection from hospitalization and death. That's been downgraded to 30%. There are issues regarding potential teratogenicity. So that question is, would people need a pregnancy test before they can use it or not? Suffice it to say, it will have a role, but it may quickly get overshadowed by a different class of drugs, protease inhibitor, the Pfizer product Paxlovid, which has gotten everybody excited because it has even a higher rate of protection from serious outcomes. And it has some very early data showing it may actually work well with Omicron as well. So that's probably slated for going through all of its approval processes at the end of this month. And with holidays and stuff, I wouldn't want to make any promises, but hopefully it'll soon be on limited number of pharmacy shelves. And then finally, Omicron. There's no question about its increased transmissibility. The question is how increased? And we thought Delta could be given to maybe 3 to 5 people by one person. Omicron, I'm hearing similar things, but that may be the lower baseline and it may get higher than that. We'll have to wait and see. Most are agreeing that there's less severe illness, but the cautionary point is that in South Africa, there's a younger population. The early populations they were dealing with were college students and other youth. So we don't really know on a large population-wide basis if that lower severity is true. We're starting to see some of that in countries like Norway and Denmark, which have had real surges. And still seems like severity may be lower, but again, because so many cases occur, there'll still be more people with serious outcomes. And then we're getting, I think, reassuring information about vaccine-induced immunity and natural immunity, but the reality is we're also hearing that they're not good enough. So that's a kind way of saying there will be a lot of breakthrough cases. And if you are coming from a vaccine skeptic philosophy, you will feast on that and say, see, these vaccines don't work. I'm just going to rely on the treatments because why prevent something with a toxic substance like a vaccine? But the reality is, yes, there will be breakthrough cases, but there will also be success stories. And this is where the role of the third dose comes in very, very handy, because that's already showing itself to be a game changer for many people, which is why we're trying to really tell the population, yesterday was the day you should have gotten your booster, so get it. It's really time to do that. I think we know how it will impact the healthcare system, and there's nothing good news in that because of the large number of cases. I also think it will impact the healthcare system because it will impact the healthcare workforce. And that's a very important and already challenged workforce. And as they start to get ill, because every part of society will get ill with Omicron, especially knowing that it can cause breakthrough cases at a high rate, it's going to impact our healthcare system in another adverse way, because the healthcare system's already challenged by having enough staffing to cover the beds that are open now. And as I alluded to earlier, it will help us in our march towards endemicity, if that's a silver lining or not. Ending on a high note, I do believe in a resilient human race. I also believe in people having a short memory, and that's why public health has been underfunded for so long, and that's why we're showing not always the best response as a country to this pandemic. We've gotten lots of money coming in for new positions in public health in the last few months. The question is, 2 to 3 years from now, will the memory of Congress, other leaders, and society in general be long enough that they will remember what needs to be done to prevent problems in the future? Because clearly, the next pandemic is not going to take 100 years to occur. We all know that. So thanks for your attention, and we've got some time for questions, and I'm happy to entertain them.
Great, thank you so much, Dr. Levine.
I have a question, Cliff Rose and Mark. A really great presentation from Vermont. I wish you had talked more about Maine, but we also have our own people in Maine. I have 2 questions. One is outcompeting Delta, Omicron. How sure are we that's going to happen? Certainly in South Africa, it outcompeted Beta. They did not have as much Delta. So how assured are we that that's going to happen? It looks like it's going to happen. Is there a possibility that it won't?
You know, that's a great question, because you're right. Everyone's saying this is what's going to happen. And clearly, there's so much of our country that is now past Delta that it will happen in those parts of the country. The real question is, in a place like the Northeast, where there's enough Delta going on still,
Yes.
how are things going to evolve? I still sort of believe in the theory of natural selection, or call it what you want, that if a virus is more adept at infecting people, it will eventually outcompete the other one. The problem is, I don't think it's going to be abrupt. So
Yeah.
this Delta surge is going to plateau for quite a period of time while Omicron is, feasting on the rest of the population, so to speak. So I think that's how it will probably play out. I will say, because you mentioned it, both Maine, New Hampshire, and Vermont share one characteristic, which is their most unvaccinated parts of their population are in the northern parts of their state.
Yeah.
Some affiliate that with the white, rural, Trump voting Republican, because that demographic has been well demonstrated across the country to be the most vaccine hesitant. And that indeed in Vermont is true, at least in our Northeast Kingdom. That's where that population is larger than perhaps other parts of the state. But having said that, our biggest counties right now are in the southern part of the state, Rutland and Bennington. And their vaccine uptake is better than what the Northeast Kingdom's was, though it's not as good as some of the other parts of the state. But clearly, one thing Vermont has different than Maine and New Hampshire right now, and Maine and New Hampshire have been churning along at a higher rate before Vermont got to the similar rate, is that hospitalizations and ICU capacity is much more challenging in Maine and New Hampshire right now.
Yeah.
Which is very curious. And they're both, well, New Hampshire not as much as Maine, but Maine is almost as well vaccinated as Vermont.
Yes.
So it's always challenging to explain every nuance of what goes on in a way that makes complete sense and is supported by the science.
The northern counties of Maine are some of the top in the country now for infectivity.
Yes.
Aroostook County in particular. The second question I had is more just in your crystal ball. Is there a likelihood that Omicron will be outcompeted by another virus that has even more mutations and that may be more contagious than Omicron?
Unless we get the pace of vaccination up around the world, the answer is almost certainly yes. That's the simple answer.
And I have a third question because I see these papers at New England Journal every week, Mark. So it looks like people who have been infected and then get vaccinated really have the highest rate of antibody production if they've been infected.
Yes.
So is that going to help us in the long run, or is it still the challenge of getting those people vaccinated because they're some of the people who are most hesitant?
Yeah, so the answer is yes and no. So we're definitely going to have more of those people around because a lot of unvaccinated people who were infected have gotten vaccinated. But there's still a core number of people who believe that the natural immunity way is the way and they're never going to get vaccinated. So I support, though, the literature, which is pretty much, I think, got a good consensus on the combination of both types of immunity is only good. You don't want to, it's hard to convince vaccine hesitant people of this, but it's quite clear that superimposing vaccine mediated immunity on the natural immunity they have really does cause a much more robust immune response. And they can't, they will, but they shouldn't be able to quarrel with the science behind that.
Thanks again. Great talk. Great talk, Mark.
Other questions?
We had one question come in through the chat. Dr. Levine, you had addressed the waning efficacy of vaccines and the importance of a booster. And the question was in regards to whether we can predict or anticipate in some way what the interval of upcoming boosters might be.
Yeah, far be it from me to try to do that. One thing that some people on this call, I'm sure, are more knowledgeable than myself, but I will put my toe in the water here. You know, the only thing we hear much about is what kind of antibody level response came from giving a shot. And as we all know, immunologically speaking, that isn't the whole game. It's not like measuring humoral antibody response is like all our body has ever relied on since the beginning of time. You know, we do have T cells and B cells, we have antibodies, but we have a lot else going on in our immune system. And a lot of it we don't measure on a regular basis. And the measurements of some of that, I think, is going to help us determine the answer to the question about boosters, because there is an immunologic memory that isn't measured by just looking at how many antibodies are in someone's bloodstream. And there is an immunologic memory that's sequestered in lymphatic tissues that has to do with a whole different arm of the immune system. And we got to get more insight into that to make decisions about when people need to be boosted or not. So I put that on the table for discussion because I think that's critical.
Thank you so much. I think we might have time for one final question. Briefly, a question came in through the chat as to whether how we're thinking about preparing for or learning about the infrastructure that we might need to support these long COVID patients.
Yeah, so, you know, around the country at various universities, there are clinics being set up. You know, long COVID now has a fancier medical term, PACS, post-acute COVID sequela. And so there are clinics that are devoted to, of course, trying to help people, but also help them in a context of a research arena. At UVM, I know that in the pulmonary medicine section, that is evolving as we speak. And there's a clinic that actively sees patients with more of a focus on the lungs, but they realize that it's much more expansive than that. So that's how we're going to learn more about this through the experiences that occur in these various university and academic medical center settings that have patients coming to them. All we know is it's a lot of people. And even if they're not all enrolled in one of these clinics, because they aren't, they're all seeing their own doctors and they're all trying to contend with very debilitating symptoms, whether it be unrelenting fatigue, whether it be orthostatic hypotension, whether it be tachycardia and exercise intolerance, shortness of breath, or brain fog. These are all pretty heavy duty complaints that don't have as much basis in physiology mechanisms that we can understand right now in terms of helping them. So stay tuned is all I can say. The good news is NIH is actually pumping some real money into this. So it's not something that's being forgotten by the scientific enterprise, but it's going to take time.
Right. Yeah, we have a lot left to learn. Thank you so much, Dr. Levine. In respect out of your time and everyone else's time, I think we'll close it there. But again, thank you so much for joining us today.
Thank you very much.
It's been a pleasure. Thank you all for your attention and turning out like this. Great.
Thank you very much.
Bye-bye.
Bye.
Thank you.